All right, let's break down the CAP protocol for invasive melanoma biopsies. If you're a pathologist in training, you know this is a core skill. And today we're going to walk through how to nail this report with confidence every single time.
So how do you make your biopsy report truly matter for patient care? Well, it all comes down to precision. A standardized, super thorough report isn't just a piece of paper. It's the critical first domino that directly affects how a patient's melanoma gets staged and, ultimately, how it gets treated.
So here's the game plan. We'll kick off with the CAP protocol itself, cover the specimen basics, and then dive deep into the big three prognostic factors. From there, we'll check out other key features, talk about margins, and wrap it all up with the most important reporting takeaways. It's a workflow, designed to get you from that little piece of tissue to a powerful, complete report.
Okay, first things first. Let's get our bearings. Everything we're talking about today is built on the CAP protocol. But, and this is super important, we're focusing on the protocol specifically for biopsy specimens. It is a totally different beast than the one you'd use for a big, definitive excision.
The whole mission here is to squeeze every last drop of prognostic information out of what's often a tiny piece of tissue. We're trying to build a complete picture from a really limited sample. So let's start with the absolute fundamentals.
So where do we even begin? Well, you start right at the beginning with the first items on the checklist, the basic info about the specimen and the tumor. Getting these right lays the groundwork for everything else.
I know, this seems like checkbox stuff, but don't just fly past it. Accurately capturing the procedure type, laterality, and especially the anatomic site is absolutely crucial. And why is that? Because prognosis can actually change depending on where the tumor is. A melanoma on the trunk might behave very differently than one on an arm or a leg.
Now, this is where things get really interesting. The way the modern WHO classification organizes these subtypes isn't just some random list. It's actually based on the underlying biology, especially the pathway that's related to UV sun damage. This really helps us frame our thinking about where the tumor came from.
All right, everyone, lean in, because this next section is critical. We are talking about the big three. These are the most powerful, independent predictors of a patient's outcome. This is where your precision matters most.
And leading the charge is Breslow thickness. Honestly, if you remember one thing, make it this. It is hands down the single most important prognostic factor in invasive melanoma. Everything hinges on getting this measurement right.
And as you can see, the technique is super specific. You find your top reference point, the granular layer or the base of an ulcer. You find your bottom, the deepest invading cell. Then, you've got to measure that vertical distance at a perfect right angle. Oh, and a key point. You do not include separate satellite nests or areas of neurotropism in this measurement.
Now here's a pro tip straight from the AJCC, and this is where it gets real. You have to report to the nearest 0.1 millimeter. And why does that matter so much? Well, picture this. Your measurement is 0.76 millimeters. That gets rounded up to 0.8. That simple rounding can bump a tumor from a T1A to a T1B, which could literally be the deciding factor for whether that patient gets a sentinel lymph node biopsy. It's a big deal.
Okay, powerhouse number 2 is ulceration. But hold on, there's a huge pitfall here. You absolutely have to be able to tell the difference between true tumorigenic ulceration, the kind with a full thickness defect and fibrin, and just a plain old artifact caused by the biopsy itself. Only true ulceration upstages the tumor.
And that brings us to the final member of our big three, the mitotic rate. This is another really strong, independent predictor of how a patient's going to do. And the CAP protocol has a very specific way we need to count it.
So the key here is what we call the dermal hotspot method. You don't just start counting anywhere. Nope. Your job is to be a detective. You have to actively hunt for the area with the most mitotic activity first. Starting your count there makes sure you're reporting the highest and therefore the most prognostically relevant rate for that tumor.
So what happens if you look and you find nothing? After a really careful search of that whole square millimeter, if you come up empty, your report needs to say that loud and clear. 0/millimeter squared or none identified. You can't be ambiguous here.
All right, we've nailed the big three, but the story doesn't end there. The tumor gives us a bunch of other clues about its behavior, and these additional features provide really important prognostic information that has to be in your report.
So you're also on the lookout for things like microsatellites, lymphovascular invasion, or LVI, and neurotropism. You also need to comment on regression and something called tumor-infiltrating lymphocytes, or TILs. Now, let's pause for a second on TILs, because they tell us this fascinating story about the patient's own immune system fighting back against the cancer.
And the distinction here is absolutely crucial. A brisk response, which is a good sign, means you see lymphocytes swarming the entire base of the tumor. Non-brisk, on the other hand, means that immune response is just focal, kind of patchy. It's a subtle difference, but it's an important one to report.
Okay, we've been deep in the weeds looking at the tumor itself. Now let's pull back the lens and look at the edges of our specimen. Assessing the margins on a biopsy is all about giving the clinical team what they need for that critical next step, the wider excision.
Your report here has to be crystal clear. Think of it as a direct message to the surgeon. Are the margins positive or negative? If they're positive, what are they involved by? Invasive tumor or just in situ disease? And which margin specifically? This info directly informs how big and how urgent that next surgery is going to be.
Okay, everybody, listen up, because this might be the single most important rule for reporting biopsies. You report all those amazing features we just discussed, but, and this is a big but, you do not assign a final PT stage. That can only happen on the definitive excision specimen, period.
All right, let's wrap this up and bring it all home. We're going to run through a final checklist of the absolute must-knows from this protocol. Getting these points right will make sure your biopsy report is clear, complete, and clinically powerful every single time.
Think of this as your final pre-flight check before you hit sign out. Get Breslow right, down to the correct decimal. Confirm you've got real ulceration, not an artifact. Use the hotspot method for mitoses. Characterize the TILs, and, most importantly, always remember your role on a biopsy is to provide the data, not the final stage.
You know, this final question is a bit of a trick, right? Because your job on the biopsy isn't to set the final stage. But what you are doing is so important. Every single measurement you take, every feature you describe, that is the foundation for every clinical decision that follows. You're not writing the whole story, but you are absolutely writing the most important first chapter.